to de-escalation, what is fluid stewardship, etc. Okay, mostly they've asked about the ROSE concept or SOSD, or else they've asked what are the 4Ds of fluid resuscitation, something like that. Okay, so coming to the presentation per se. So we know that the latest surviving sepsis guidelines was given in 2021, okay, in which they suggested that at least 30 ml per kg of IV fluids of crystalloids should be given within the first 3 hours. Along with that, what they suggested is the use of dynamic markers for fluid responsiveness to initiate or carry on with fluid resuscitation. Both of this, as we can see, are weak recommendations with very low quality of evidence. What is more stark is when compared to the 2016 recommendation of the SSG, the recommendation was downgraded for the 30 ml per kg of IV fluids because they had solid evidence from the trials like Process Promise and Rise, which showed that one size fits all is not going to be the way forward because there are a lot of effects of fluid resuscitation and fluids need to be treated like drugs. That is what they emphasized on. Okay. So where did all this start? It all did started in 2001. Actually, the start of the millennia was when the whole world looked at EGDT because it was a protocolized approach for the management of septic shock. It was a very great way of resuscitation because there was one protocol which was given and universalized later on for almost a decade, okay, wherein it showed few of the markers which could objectively be used for a septic patient so that we achieve certain goals. So we are in the same way. So this was what was challenged. So after 10 years of this, the Australasian group and others tried to look at the effects of the EGTT on mortality, or was it, based on evidence? So the ARISE trial was published in 2014. They used the MAP target of more than 65 of Hg, and the initial fluid bolus was 1 liter of crystalloid within the first hour. The average fluid volume within the 6 hours was found to be roughly around 2.5 liters. What they found out was there was no significant mortality difference between the EGDT guided resuscitation as compared to usual care. So they found out that a protocolized based resuscitation was not superior. This was reflected in the other trials which were following it, that is the process trial and the promise trial. In this also, you can see that the initial fluid bolus was roughly around 20 ml per kg, with a mean volume in the 6 hours being 2.8 liters in both the groups. So roughly whatever said and done, what the overall summary said was there was no mortality benefit with early goal-directed therapy. There was no survival advantage with the protocol-based approach as seen in EGDT. 90-day mortality was similar across all the groups. The standard, care of evolution, which usual care is what it is referred to as, was something that evolved from reverse trial. Okay, early recognition and treatment of sepsis, which was the hallmark of the study, became universally accepted. Protocol flexibility is what was called for. So the overall impact led to more individualized approach to sepsis and less aggressive fluid resuscitation. Okay, so this leads us to the most important question. How do we approach a case of septic shock? So EROS is the latest concept. What I want you guys to understand is, in this class, I'll not be talking about fluid responsiveness, which has already been dealt before, okay? Only practical concepts related to fluid resuscitation is what we are going to discuss. The 4 pillars of the EROS concept involves an early recognition of the shock stage with identification of the source of infection. Along with it, resuscitation and rapid establishment of tissue reperfusion is what needs to be achieved. Providing organ supports, especially when it is failing, becomes very much necessary for preventing the further cascading effect of septic shock. Source control includes early adequate antibiotics, drainage or debridement of the infectious focus as early as possible. So these is what comprises of the EROS, that is early recognition, resuscitation, organ support, and source control. So in early recognition, what we need to focus is on clinical examination as well as history, use point of care ultrasonography, appropriate imaging whenever it is necessary, and microbiological sampling and culture with initiation of antibiotics as early as possible. Okay. Resuscitation is starting of adequate, fluid therapy, timely initiation of vasopressors, inotropes if required, and transfusions if necessary, especially in case of a major trauma like a open, fracture, etc. Organ support is early initiation of invasive mechanical ventilation, renal replacement therapy, and extracorporeal therapy whenever it is required, as and when the resuscitation progresses. Source control is the main pillar of the ERAS concept. We need to make sure that if there is a source of sepsis, that needs to be identified at the earliest and has to be mitigated. Otherwise, doing any other thing would be futile. So whenever we get this patient, these are the things which we usually look at in our examination. So we look at the vital signs. Usually they would be abnormal, indicating a drop in blood pressure, tachycardia, tachypnea with probable raise in temperature, because of which there would be poor tissue perfusion, leading to delayed capillary refilling, mottling of skin, cold extremities, and decreased urine output. Along with this, what other thing would we look at? Usually, they are called as three windows of shock, especially in septic shock. One is skin that, or delayed capillary refill. The other one is urine output. Other one would be the third window is the mentation. Okay, that will also be down. And laboratory markers, as indicated in any shock stage, usually leads to elevated lactates, base deficit, and SCVO2 of less than 70%, and blood gases would be usually showing a trend towards metabolic acidosis. So what would we do? You've already taken the history, you've done in some labs, and you've got some values which indicate towards a shock state. So according to the Surviving Sepsis Guidelines of 21, what it initially suggests us to do is administration of a crystalloid for a 30 ml per kg volume within a span of 3 hours. After this, it asks us to reassess the volume status and tissue perfusion. If found adequate, stop the fluid bolus. If inadequate, that is, if the lactates are still high, if the patient is hypotensive, probably we need to consider addition of vasoactive agent, or probably another fluid bolus might also be suggested. So when do we say it is adequate? Usually the targets are a MAP of more than 65 mm of Hg, an SCVO2 of more than 70%, or normalization of lactate or lactate clearance. So based on various trials which have been done, especially the ARISE trial, as latest as the Andromeda shock trial, what is the lactate clearance that is advised as, which is significant? I need you guys to unmute and answer this question. It's your Viva question also.
10% lactate.
Excellent. Up to 10% is suggestive of significant lactate clearance. Okay. So anything more than 10% is great. If you have a 20 to 30%, that means to say the resuscitation has been, very good. Or else the patient has a better chances of, getting out of the septic circle. Okay. So whenever you reach these targets, you can stop fluid resuscitation. So in resuscitation, the goal of resuscitation is to rapidly establish tissue reperfusion, thereby increasing the delivery of oxygen and maintaining the oxygen content of the blood, and by in turn also maintaining the neat arterial pressure. Okay. So the goals of resuscitation involves restoration of the volume, support of the blood pressure, improvement of cardiac contractility, and replacement of lost blood components, if any. How do we do it? That is restoration of volume by fluids, blood pressure by vasopressors, contractility by inotropes, and lost blood products, if any, by transfusion of blood products. So fluid management in sepsis and septic shock, the basic concept, you have a vasodilatory stage which leads to maldistribution of bloods to organs. That is, there is no high quality evidence to show that there is, if at all you give a large volume of fluid, it is beneficial. Okay. Many times that has been seen that we use this IVC collapsibility, even SVC collapsibility, or the use of CVC as one of the parameters to see that. But there is no robust evidence to show that this can give us an example or a guidance tool for better resuscitation. More or less, what usually happens in this phenomenon is in a state of volume overload. So always don't go by the concept of overloading the patient and subsequently diuresing the patient to reach the recovery status. Okay, because this concept has found to be a not viable concept or poorly, physiologically sound. So what usually happens is because of volume overload stage, the euvolemia usually would be appearing after adequate resuscitation and probably after diuresis. When you go to the over resuscitation stage, there is always a risk of damaging the endothelial glycocalyx, wherein it sets forward a vicious cycle of probably causing acute kidney injury or fluid overload syndromes in the patient. Okay. Fluid bolus therapy is usually not evidence based. Whenever possible, use dynamic indices of fluid responsiveness and guide your therapy. So, coming to a few terminologies which are associated with fluid resuscitation. What do we mean by resuscitation fluids? It is the fluid which is given to the patient in the initial phase of shock, usually targeted at perfusing the organs, which is usually done to normalize the lactates or have good lactate clearance. What is fluid creep? A term that refers to unintentional, unmeasured fluid volumes which are administered in the process of delivering other medications. That might be antibiotics, sedatives, painkillers, etc. It can also involve your NG feeds, okay, or any other enteral or parenteral nutrition. Maintenance fluids are fluids, a source of water, electrolytes, or any other potential source of glucose that is aimed at covering the basic caloric intake of the patient when he is critically ill. De-escalation and de-resuscitation usually involves the process of removal of excessive fluids in the body in a phase of fluid resuscitation. That is usually after you have finished your first two steps, that is salvage or resuscitation and optimization. Okay. Fluid creep usually attributes to around 33%, and nutrition attributes to roughly around 33% also. So these three things usually tend to be ignored in the ICU, and this is usually what adds on to the cumulative balance over time and causes volume retention in the patient, which can be detrimental in the long run. So, what is the concept of ROSE? Usually, it stands as an acronym for resuscitation, optimization, stabilization, or evacuation or de-escalation. As you can see in the graph, you have the cumulative fluid balance in the y-axis and time over the x-axis. What usually the resuscitation phase consists of is the fluid resuscitation, which adds on in minutes to several hours after the diagnosis of a patient being in sepsis with probable hypotension or septic shock. Usually, the target would be to give this patient around 30 ml per kg as the surviving sepsis guidelines within a span of 3 hours to achieve a target of 60 to 65 mm of Hg. So what do we do in optimization stage? The optimization stage usually happens from hours to usually the first 2 to 3 days of septic shock or sepsis. So what we usually try to target is the normalization of the capillary refill or the CO2 gap. Okay, in such this thing. Basically, we are looking at adequate cardiac index. You're trying to reach that stage. Stabilization phase is the phase where you want to achieve euvolemic state. Okay, so usually this question might be asked in multiple exams as well. And which stage of fluid resuscitation do you want to achieve euvolemia? That is usually in the stage of stabilization. So that can occur between several days or towards a week. Okay, and de-escalation is usually over a period of a week, and therein you try to remove excessive fluid in the body. Okay, that is post resuscitation. So, what usually is suggested is, as compared to the surviving sepsis guidelines, in resuscitation phase, use smaller boluses, that is up to 4 ml per kg. If they ask you about ROSE concept, start with this. Okay, I've told you in the previous slide, it's about SSG, correct? So, in the ROSE concept, what they asked is, but instead of 30 ml per kg, start with a smaller bolus, that is 4 ml per kg, and start with early norepinephrine to usually when the patient's diastolic shock index is more than 2.3, or the diastolic BP, which indicates a state of vasodilation being 50 less than 50 mm of Hg, start early norepinephrine. In the stage of optimization, what would you do? The intervention is usually to check the fluid responsiveness, usually use dynamic markers, and start adding colloids in such state. Usually, what is suggested is the use of albumin. Based on the SAFE study and the Albios study, what usually was found is whenever there is large volume resuscitation that is necessary to reduce the volume of resuscitant fluid necessary, it can be substituted by the use of albumin. Okay, it has not shown to be inferior, or sometimes it has also shown to have lesser length of hospital stay or the occurrence of ART, I mean, need for acute kidney injury and all of that. So in that case, you can use albumin. So that is what is suggested in the optimization phase. Coming to stabilization phase, as I've already told you, look for getting a euvolemic state. Okay, you can minimize the use of maintenance fluid, or if not necessary, please stop it. Okay, in this case, you have to look into the fluid creep, which might have happened in the first 2 to 3 days or up to a week. Okay, because of multiple infusions which the patient might have received, like sedation, or probably even nutrition wise also, you might have given a lot of fluids to such patients. So that has to be optimized at this phase. In the evacuation phase, usually you tend to get the patient back into a little negative balance or euvolemic status. That time you might have to use diuretics. If diuretics are not working and this patient is still looking a little volume overloaded, then you might consider the use of ultrafiltration if needed. Okay, it might be with or without the use of albumin. So coming to the next thing, okay, so what fluid do we use? So usually what is considered is colloids or crystalloids, right? So if the type of fluid is what you need to consider, so the current evidence does not support the use of colloid as the first resuscitant fluid, okay? So the theoretical advantage of colloids remaining in the intravascular compartment for a longer period, thus potentially limiting the overall resuscitation fluid, was futile. I mean, it was not sound. So SSG clearly says that don't use colloids as the first thing. But if you're thinking of colloids, the best thing would be the use of albumin, usually in this optimization phase, as I've already mentioned in the previous slide. So the use of starches is totally, obsolete as of now, because it has caused more damage than, benefit in the long run. The damage ranging from renal failure, coagulopathy, transfusion, and allergic reactions. So the success study especially showed that the use of colloids had a higher 90-day mortality as well. Okay. So use of hyporisocortic fluids like 4 to 5% albumin was found to be safer in septic shock. The cost benefit ratio is what needs to be thought about. Always remember, albumin should never be the fluid of choice, especially when you are resuscitating a patient with traumatic brain injury associated with raised intracranial pressure. So if you have a patient with TBI, if you're thinking of albumin, strict no, you know why. Okay, so it can usually cause raised ICP. Okay, so that is one of the reasons you need to consider this. So this might be one of the questions they might ask you in your Viva session if you take up albumin. Okay, so they might trick you by telling you the patient in day 2 has fever, septic shock has come in, I'll give you albumin. Do you want to give albumin? Probably the patient was mild to moderate TBI, did not get any decompression at that time, and still you're using anti-edema measures. So be aware of such things. Okay, TBI, there is no role for albumin. In a small study, as I told you earlier, whenever the volume of resuscitation was high, if the use of 20 to 25% albumin was only beneficial to reduce the volume of resuscitation. Okay, but still larger trials need to be used for us to come to a conclusion. The Albios trial showed that supplementation of 20% albumin infusion in addition to crystalloid infusion was associated with mortality benefit. So this is one thing that they found out. Okay, so this is something that I want you guys to remember, that what I need you to remember here is it was in addition to a crystalloid infusion. So first choice is always crystalloids followed by colloid, that is albumin, only albumin and not starches at all. Okay. So next question is crystalloids versus balanced salt solutions. So what is the role right now? What do you guys I mean, you guys might have been told about this multiple times, right? So what is the problem statement with the use of crystalloids and balanced salt solutions? Okay.
Mhm. Crystalline
Mm.
hyperchloremic metabolic acidosis can occur.
Correct. So that's good. That's good. Okay. So that one of the major problem was the high chloride load and potential for renal hyperperfusion through tubulogranular feedback mechanisms, which are usually seen in crystalloids. That is usually the saline, that is 0.9% saline, but we routinely use as a resuscitant fluid. The strong ion difference was found to be around zero, and the causation of hyperchloremic metabolic acidosis was high. So even though they say this, the surviving sepsis guidelines clearly indicate that the balanced crystalloids is the first resuscitant fluid that we need to consider in a patient with septic shock. Okay. What is the evidence for balanced crystalloids versus balanced salt solution with versus crystalloids currently?
Split smart trial
Yeah,
basic
great, great, great. Some more.
basics plus.
What was, did they find any benefit?
Um,
Basics trial was there recently, or any other thing?
Precipitation illness and crystal balance salt are same,
Okay.
almost same.
Good, good. What did they find out? Was there any benefit? See, the whole concept is we thought that is metabolic acidosis. Metabolic acidosis can cause problems to kidney. So what they looked at is what is it causing? Well, first thing, is there any mortality benefit? That is what we need to look at most of the trials, right? In critical care, most of the things are focused at mortality benefit. The second thing, usually what they look at is renal replacement therapy, acute kidney injury, or organ damages that is associated. So what they usually looked at all of this is make 30, okay, made a adverse kidney events on the day 30. So what they found out was there's no benefit. I'll just discuss, okay. So restricting the use of chloride liberal fluids improved renal outcome. That is what they found out. That is balanced salt solution better than crystalloids, that is saline. The SMART study, like you all mentioned earlier, what they found was composite out, it had, use of balanced crystalloids, probably ringer, had lower composite death outcome, renal dysfunction, need for renal replacement therapy, as seen with make 30 events when it was compared with 0.9% saline. The SALT ED trial also showed the same thing, that is, reduce the length of hospital stay and lesser incidence of make 30. However, looking at the trials which I've already mentioned earlier, you see this particular table, I just want you guys to look at very closely and remember at least a few trials, okay? Whenever there is a question about balanced salt solutions versus crystalloids, this thing can come in your table viva. Okay. So recently, when we had our interaction session, most of you asked us how to speak about, a trial if it is given, how to go about it. I told you about the use of PICO questionnaire. So this is how it is usually summarized in major articles as well. See, if you can see here, it is the population, intervention, comparison, and outcome. So this is how we have to go through. So when we see here, it is actually put it in a chronological order from the year which was published. Okay. So in this particular study, what is our focus on? Balanced crystalloid solutions versus normal saline. So this patient population, it is all the ICU patients, okay? And the intervention group usually consists of the balanced salt solution. The comparison was in normal saline, correct? So this is what usually you need to see, and then you need have to look at the outcomes. In the trial, if at all it is given as your critical appraisal paper, look at the primary outcome and the secondary outcomes. Okay. So you need to usually talk about them. In the statistics class, we'll let you know how to go about each one in a small format. Okay. So this is usually the way that you need to write as well, if at all they ask you in a exam also. So they might ask you a question. Write about the evidence of balanced salt solution versus novel saline and septic resuscitation or something like that. So critically analyze or something if they ask you in that lines, you need to answer in such headings. Okay. So what we can see is they have done a large interventions. The basic trial was one of the recent one. After that, plus trial came in. So until up to the split and the salt trial, along with salt, there was another trial I mentioned earlier, the salt ED trial. Okay. So what they found out was there was no major difference which was seen. Later on, smart trials showed that the use of balanced salt solutions was, leading to lesser occurrence of renal damage as well as the need for renal replacement therapy. Also going on to show that it required lesser hospitalization. but that was actually offset by basics trial. They saw that they told that there was no significant decrease in the acute kidney injury and mortality within 90 days. But when they did the subgroup analysis, they found out that there was a higher 90-day survival in patients who received balanced crystalloids. Okay, so that again put us into a lot of debate as to what happened. And then subsequent year in 2022, there was another study which was published, that is the PLUS trial, which again went back to the initial evaluation, showing that there was no difference. So currently, whatever is said and done, what they're asking us to do is the use of balanced salt solution is theoretically sound and physiologically sound. So whenever possible, use balanced crystalloids as much as possible and avoid normal saline. Okay, so the thing in these two trials, there are a lot of biases which were there. So if you go to the study per se and then read about it, you will understand. For now, practically speaking, because these two are something which is major, that is occurrence of acute kidney injury in the ICU stay, probably the use of balanced crystalloids is good. Okay, so to take home point in this particular question about balanced solutions versus normal saline, use balanced crystalloids as much as possible. Okay, and that would be answered by two things, that is length of hospital stay and occurrence of make 30 events. Okay, so the next question would be the dose of fluid. So how do we dose? We already spoke about 30 ml per kg within the first 3 hours in SSC guidelines. So, but this was widely criticized, right? It got downgraded even from the recommendation guidelines to a suggestion guideline from 2016 to 2021. What usually happens is the evidence for this was lacking in most of the trials, which was already mentioned previously. So this is one of the limitations of surviving sepsis guidelines as well. Okay, so they usually consist of a lot of RCTs which are usually not powered to what effect we want to look at. Okay, so weight-based fluid resuscitation is something that needs to be individualized, and that would be futile if you take just a round number of 30 ml per kg for all the patients. Along with that, you need to know the hemodynamic status of the patient as well as the comorbid illnesses of the patient. So for this reason, what they found out was if you use 4 ml per kg body weight, as mentioned in the roast concept, that would be a little more judicial way of approach to dosing the fluid in sepsis and septic shock. So subsequent use of fluids should only be based on fluid responsiveness. That is usually what you need to do is use a dynamic test of fluid responsiveness to guide your fluid resuscitation. Fluid challenge should not be repeated, especially if you have a negative or a equivocal response to fluid responsiveness. So the next question would be when to initiate vasopressors. So we spoke a lot at length about type of fluid, the dose of fluid, but when do we start vasopressors? Anyone? See, these things should be answered quickly, okay? Because see, this is something you guys are doing from the time you join the course or probably before as well, right? So you will have some idea. Please commit to some answer so that we'll take it from there, okay? Don't worry about it being right or wrong.
As per classic and Clover trials, early vasopressor initiation is
Classic and Clover trial, okay. When did they say that? At what time? Any other trial which came up? Classic and Clover trial did not, actually they mentioned that, okay, but that was not focused at that, okay. So usually whenever we talk about this, no, we should see if it was intended to address that issue. Yeah, but that has subgroup analysis showing that. Excellent. Anything else? Early initiation means, okay. So in patients, whenever there is a diastolic blood pressure of less than 50 mm of Hg, you can start fluid and vasopressor. Okay. So this need not wait for your 30 ml per kg SSG or 4 ml per kg body weight with fluid responsiveness time and again to reach there. Probably you would have started a cascade of organ damage by then. Correct. What we SSG says is wait for 3 hours. What Rose says is do it every 15 minutes to 20 minutes. Probably at that time, patient might have worsened and he would have required more organ support by then. What if the patient had gone into acidosis? What if the patient had gone to hypoxia requiring ventilation? So these things could have been offset, right? So that is what they said. Use of diastolic shock index, especially if it is more than 2.4, indicates the initiation of vasopressors. So it is usually reasonable to start vasopressor infusion after initial 1 to 2 liters of crystalloids. But if at all it is before that, you see these signs like above, that is the diastolic shock index or the diastolic blood pressure being low, you can start vasopressors as early as possible. Along with the trials mentioned before, the refresh study was usually focused on initiation of norepinephrine after 1 liter, and it had shown to reduce the cumulative fluid balance as well. Okay. So observational study dose of vasopressors in the first, whatever 6 hours of septic shock, if you delay it after that, it was shown to have higher mortality. Okay. So if at all it was initiated earlier, and especially after 2 liters of fluids, the effects were found to be beneficial. Okay. So this is something, it is quite against what SSG advocates at present. Okay. So this is what I need you guys to understand. So whenever you have a patient with septic shock, don't wait for first 3 hours, 6 hours, etc. Start fluids, probably 1 liter or 2 liter, or based on the patient's comorbidities. Look for fluid responsiveness. If at all the patient is in shock, if you have an art-line in situ, or else you have checked the blood pressure to be less than 50 mm of Hg at the time of arrival, probably it is fair to start vasopressors after 1 or 2 assessment of fluid resuscitation. By this, I don't mean that as soon as the patient comes to your ER, check the BP. If it is 80 or 40, start NORAD. No, it doesn't mean that. You need to give fluid. You need to reassess the patient after 1 or 2 boluses and then start the vasopressor. Okay. I hope I'm clear about that. So coming to liberal versus conservative fluid therapy. So what do you guys understand by liberal versus conservative fluid therapy? So coming to the concept of liberal versus fluid therapy, this came into picture, especially after EGDT, surviving sepsis guidelines following that, coming and the use of various other trials like ARISE process promise, giving us larger volumes of fluid resuscitation to mitigate the organ injury due to septic shock. So what happened was there was large amount of fluids being pumped into the patients with sepsis, along with blood products in a few centers, which still followed EGDT. So the whole thing, if you see here, the population intervention comparison and outcome was wherever they used these things, they looked at the hospital mortality as the goal, okay, or the outcome. So in the EGDT, surprisingly, they found out there was significantly lesser in hospital mortality, especially with Apache scores and SAP scores and mods being reduced if they followed EGDT. There was another trial called the FEAST trial, which was usually the sub-Saharan African children, which showed that albumin boluses, if given to the patient, was associated with mortality. Okay, so this kind of got a lot of confusion associated. So then came the ARISE promise and process trials, which said that no, you can go ahead with around 20 to 30 ml per kg body weight, but still there was no mortality benefit associated with this particular volume. Over time, the recent trials like the Classic and the Clover trials also looked at the use of restricted fluid strategy with liberal fluid strategy. Even at this particular time, the thing is there is no difference between liberal versus restrictive fluids, which is seen in the resuscitation of septic shock. So the question still remains. There were multiple other trials along with these things which looked at liberal versus conservative strategy. One being Andromeda trial, etc. Okay, so what they saw in Andromeda was the normalization of capillary refill time, lactate, and up to something, some point even about the end-tidal carbon, sorry, not end-tidal carbon dioxide, the CO2 gap, that is the arteriovenous CO2 gap as well. Okay, so they looked at whether that can be normalized with restrictive group people. So even in these studies, they did not have any solid evidence to prove this. So we are still waiting few more trials which are coming. That is the ARISE. I'm not sure the part of it. There is one more ARISE which is coming. Along with that, there is the Andromeda Shock 2 trial which is coming. So probably these trials can help us understand so whether there is any new evidence which can come around liberal versus uh, restrictive strategy. For now, all that you guys need to remember is there is no difference between restrictive versus liberal fluid resuscitation and sepsis with septic shock, but it is advisable to avoid volume overload. That is something that we need to understand. So how do we do that? Probably start low, don't overload your patient. Always use markers of fluid responsiveness to guide your fluid therapy as and when possible. So how do we do the assessment of fluid responsiveness? It's already been mentioned before. Use of static markers like CVP or pulmonary capillary wedge pressure are not a good indicator. Use your dynamic markers, especially the PLR, pulse pressure variation, stroke volume variation. If the patient is on ventilator and like test like end expiratory occlusion test and all can help you understand the fluid responsiveness in this patient. Okay, I'm not going into detail of this, but this is something that you need to understand when you're resuscitating the patient. Capillary refill time, as per Andromeda shock trial, has also shown to be beneficial when used for assessing the first to diagnose poor perfusion as well as normalization for improvement in resuscitation. So you can use it as a diagnostic tool as well as a target resuscitative tool as well. Okay. So anything capillary refill time of more than 4 to 5 seconds is said to be poor. Less than 2 seconds is supposed to be excellent. Okay. So what are the effects of fluid overload is what we need to understand. So till now, whatever we have spoken is about how do we start fluids, when do we start fluids, what fluids to start, how much to start, and when to stop. Okay, so you need to understand these concepts. Along with this, when you have already resuscitated the patient, there is always a possibility that we overdo, correct? Because there is no gold standard method wherein which says that, okay, you have achieved this target, you can stop. Probably your MAP would have achieved 65%, but still your lactates would be high. Probably the urine output is not good. It's probably, you're looking at cardiac contractility or ventricles being kissing or IVCs like collapsing. So these are clinically possible scenarios that you will be looking at, and based on one of these things you might have gone ahead and given fluids. So what usually happens, the patient usually ends up in a state of fluid overload that can be seen as tissue edema, pulmonary complications, cardiovascular effects, renal problems, coagulation problems, and other systemic issues. So usually these things can be evaluated by our VEXIS, right? So VEXIS is a great tool for us to know if the patient has gone into a state of fluid overload. So if at all the questions come about VEXIS, then you can talk about effects of fluid overload in these issues as well. Okay, first answer about VEXIS, and then if they ask you about other things, then you can write the principle or why it was done. It's because if you have tissue edema, it leads to impaired oxygen diffusion to the tissues. It can lead to pulmonary edema, increased work of breathing, and worsen the gas exchange. Cardiovascular effects, usually it leads to increased cardiac payload, probably dilutional effects on the hemoglobin and reducing the oxygen delivery. Excessive back pressure in the kidney can worsen the GFR. Okay, and in worst case scenarios, because of excessive fluid resuscitation, there can be risk of development of abdominal compartment syndrome leading to acute kidney injury as well. Because of dilution, there can be dilutional thrombocytopenia as well as coagulopathy, which can set in volume overload. Excessive fluid accumulation in tissues can cause gastroparesis, which is usually seen in septic patients. Hepatic congestion is usually seen as transaminitis, which also further goes on to worsen the overall outcome. Okay. So cerebral edema is one of the polycompartment syndromes as associated with abdominal compartment syndrome, which is also seen in case of fluid overload. So what do we usually do? So whenever you see this, always go by your ROSE concept or SOSD concept. So see if you have done one of these properly. If it is done in the correct order, that your fluid boluses are optimized, you have achieved neutral fluid balance, and you have started evacuating the patient, then it is okay. But if it is not, if you see one of your markers of fluid assessment is showing one of these. So that time probably you might have to start initiating this patient de-resuscitation process. Okay, so accumulation can cause a lot of problems I've already mentioned to you earlier. So if at all you have this patient in one of these issues, the treatment would usually be initiation of diuretics. You can use a combination of diuretic therapy at that particular time. You can combine a loop diuretic with a thiazide or else a potassium sparing diuretic. Also, if the patient is in the ICU for a long period of time, your diuretics usually do not work if the albumin values are lower. Okay, is less than 2.4 to 2.2. The efficacy of delivery of diuretics become a little difficult. So probably at that time you can consider the use of albumin. It can help in both the ways. It can help in reduction of fluid resuscitation as well as better action of diuretics. Probably if this is futile at that particular time, you can think about isolated ultrafiltration, which can help in removal of excessive fluid in the body. Along with that, other supportive care to reduce the intra-abdominal pressure, abdominal wall compliance can also be thought about. So if you have reached all of this, probably the patient would clinically improve. Okay, so de-resuscitation is the way forward, and the patient has ended up with fluid accumulation syndrome. This is not universally accepted. Most of the societies do tell that it is still theoretical because it does not involve everything together. Most of the time we see these things in isolation. Probably you see only acute kidney injury or pulmonary edema. Rarely you can even see gastroparesis. So this as a polycompartment problem is still not robustly studied nor has been usually accepted in most of the places. So coming to the concept of fluid stewardship, this might be one of the questions they can ask in theory. Okay, they've already asked once, what is the 4 Ds of fluid resuscitation? The 4 Ds of fluid resuscitation is drug, dose, duration, and de-escalation. What they mean to say by this is they're asking us to look at fluid as a drug. Okay, so it has to be dosed, it has to be for a particular duration, and it has to be stopped. So this is something that we need to understand. So the questions that you need to understand in fluid stewardship is the first 4 questions. That is, when do we start IV fluid? When do we stop the IV fluid? When do we start removing fluid? And when to stop removing fluids. Okay, so this is very easy to remember. Stopping of IV fluid, when do we start removing, and when do we stop removing? So this is something that we need to understand. So all of this you can remember by putting the graph of the ROS concept. Okay, that is your resuscitation, optimization, stabilization, and de-resuscitation. So when you're using that, you will understand. And this is the first 4 questions that need to be addressed in fluid stewardship. These things usually maintain based on resuscitation, maintenance fluid, replacement fluids, and nutritional part of the IV fluid. So if at all this is not done, so if you continue, erroneously continuing the fluids for a longer time, usually this leads to multiple hits. That is, the first hit is the initial insult. Okay. The second hit would be because of ischemia and reperfusion. And the third hit usually happens because of fluid accumulation and global increased permeability syndrome. This is something which is also seen in cases of dengue. Okay. So, and the fourth hit is because of organ damage, which has happened because of fluid accumulation. So, we need to understand that we need to prevent these 4 hits. Okay. So this is what is roughly about fluid stewardship. So the take-home messages is fluid resuscitation remains a vital part of management of sepsis with septic shock. Use balanced crystalloids and with frequent assessment. Assess for endpoint of hemodynamic resuscitation. So you should always know one thing about this. Okay, when do we stop? That is something that we need to know. Okay, so early introduction of vasopressors may be necessary. And remember, the goal is to optimize and prevent end organ damage whenever we are thinking of fluid resuscitation. Thank you. Any questions? So Guys, I guess we need to have more participants. Okay, the thing is, we need you to react. I mean, react, respond, or ask whatever you want, so that we'll be able to help you in the long run. So the next topic would be hyperbaric oxygen therapy. Okay. So this question has not been asked till now, but what we are looking at is many of the things in the current exam patterns are, especially the latest advances. So sepsis, mostly they were asked a lot of things prior. What we saw in the current critical care update book, that is the 24 update, was the role of hyperbaric oxygen, immunomodulation, etc. So we added these classes especially because these might be one of those sub questions which may be asked in your exam. Okay, it's not like it is very important, it is routinely and widely used in most of the centers, but these, since it is there in the update book and it is being stressed upon, maybe this is something that you need to know. And recently, even in fungal sepsis, I think so, you guys heard about the use of hyperbaric oxygen therapy. So the outline would be under the following headings: introduction, principle, methods, uses, and contraindications. So whenever they give you a bouncer question like this, always divide it under these headings or any headings, whatever comes to your mind, and then answer them in that. So if you don't remember anything also, you will be able to answer one or two sentences in these headings. Probably that will help you fetch a few marks. Okay, always it's better to get two or three rather than getting a zero out of whatever marks there, right? So that is the whole goal in a bouncer question. So hyperbaric oxygen therapy in critical illness.
Not visible, sir.
Oh, is it? Sorry. Now?
Yes.
Okay. Of introduction, principle, methods, applications. If they ask you about any method per se, you can use this. Depending on the type of question asked, you can modify the headings. Okay. So in hyperbaric oxygen therapy in critical illness, the basic concept revolves around the use of 100% oxygen under atmospheric, more than 1 atmospheric pressure. The usual thing is 1 atmosphere. Whatever is beyond that, usually it's 2 to 3 atmospheres, what is targeted as. Okay. So it is usually delivered in specialized chambers and creates a hyperoxygenated state. The primary mechanism which it revolves around is increased dissolved oxygen delivery in the plasma, and it usually is independent of the usual or the routine hemoglobin transport of oxygen. Okay. So the critical care applications usually revolve under very specific conditions that I'll be mentioning in the further slides. Usually used in various life-threatening situations like carbon monoxide poisoning, central retinal art occlusion, I'm sorry. Along with that, like, decompression sickness, etc. It has also been shown to have grade 1 recommendations in severe infections related to gas producing organisms, especially gas gangrene. So the key concept of use of hyperbaric oxygen therapy is the combined anti-inflammatory effect, especially which is seen in pro-inflammatory status. Okay, along with the effects of hyperbaric oxygen on bacteria, that is the antimicrobial properties, it angiogenic properties, that is in the enhancement of wound healing, and in patients with probable transport issues, that is usually seen in cases of carbon monoxide poisoning or one of the toxemias, that is to improve the tissue oxygenation. Okay. So what is the whole thing about hyperbaric oxygen therapy that you need to remember? The key points are usually, as you can see in the image, there is a patient. It requires a specialized chamber in which the patient is usually placed. The first and foremost thing is the patient gets 100% oxygen at 2 to 3 atmosphere. There will be multiple sessions. Okay. The sessions are usually based on the condition. So what does this do? It helps in producing higher external PO2, which creates a positive gradient, and oxygen diffuses through the alveoli into the bloodstream. Okay. And this creates increased tissue oxygen delivery, which is independent of hemoglobin. This is very much important and very much possible only because the atmosphere, what we are using, the pressure is 2 to 3 atmospheres. Okay. Physiological effects which happens because of this way of transport of oxygen is hyperoxia and hyperoxemia. That is, hyperoxia refers to the tissue delivery. Hyperoxemia is the presence of oxygen in the blood. Okay. By this, it reduces the tissue hypoxia, thereby increasing the production of reactive oxygen species and reactive nitrogen species. Okay. This usually helps in upregulation of certain growth factors, promotes neovascularization, and enhances immunomodulatory properties. So, this is the key principle. Put the patient in one of the chambers whenever it's necessary, usually 2 to 3 atmospheres. It causes transport of oxygen from the alveoli to bloodstream to the tissues, especially it is independent of the amount of hemoglobin which is present in the body. It causes hyperoxia and hyperoxemia that leads to production of reactive oxygen species and nitrogen species, which causes upregulation of growth factors, neovascularization, immunomodulatory properties. Okay. So the angiogenesis is usually because of the production of epidermal growth factor and vascular endothelial growth factor and the increase in production of endothelin-1 that is associated with increased tumor necrosis factor alpha, increased matrix metalloproteinase 1, and tissue inhibitor of metalloproteinase 1. Okay. So this usually causes the production of angiogenesis. So the other property is the antimicrobial property. This causes downregulation of neutrophil activation, decreased WBC rolling. It also causes the decrease in production of TNF alpha and interleukin 6 and decrease in interleukin 10. Okay. This is usually the pro-inflammatory markers. What it usually does is it increases the anaerobic bacterial killing and also causes biofilm shrinkage. The immunomodulatory action of hyperbaric oxygen is because of increased production of oxidants, which causes a production of decrease in production of nuclear factor kappa beta and decrease in interleukin 6, which has direct effects on the T helper cells. Okay. So what usually is the angiogenesis enhancement is something which we see in the flaps or the wounds whenever it is focused on those things, especially when you have that angiogenesis is suboptimal or the wound is chronically not healing. At that particular time, if this was initiated, they found better results. And that particular time, the mechanism by which it enhances wound healing is the improvement of angiogenesis. What we are focusing is morely towards the antimicrobial activities, especially due to the downregulation of certain pro-inflammatory markers and usually causing anaerobic bacterial killing and biofilm shrinkage along with immunomodulation. Okay, so this is what we are more focused at. So what are the indications for hyperbaric oxygen therapy? As I've already gone through this, there are 14 to 16 indications which are actually grade 1 indications, and mostly it involves around the gas embolism, carbon monoxide poisoning, serial clostridial myositis or myonecrosis, decompression sickness, refractory osteomyelitis, etc. Okay, crush syndrome is also one of the things, and chronically non-healing ulcers or poor flap uptake is also another indication. So they can be divided into multiple ways. That is emergency indications that is seen in decompression sickness, gas embolism, spinal artery cord infarction, central retinal artery occlusion, and carbon monoxide poisoning. Urgent indications usually seen in trauma, sensory neural hearing loss, and compromised flaps or grafts. Elective indications is usually seen in late radiation tissue injury, hypoxic wounds, chronic refractory osteomyelitis, and avascular necrosis. So what we are usually focused on in the current thing is the antimicrobial effects that is usually seen because of increased neutrophil function, increased antibiotic efficiency, biofilm disruption, and increased oxygen-free radicals, which causes antimicrobial effects. Okay. So the other things like wound healing, angiogenesis, and medical emergencies, it's quite straightforward to understand. In wound healing, it basically improves the growth factor production, whereby it improves angiogenesis and recovery. In medical emergency, it is the oxygen cascade which we were looking at, which is independent of the hemoglobin and the gradient which is present. So at that particular time, it helps in better supplementation or delivery of oxygen to the tissues and prevents effects of hypoxia. Okay. So coming to hyperbaric oxygen therapy in sepsis, you can remember under these four headings, that is direct antimicrobial effect, anti-infective effects, influence on the host immune system, and adjunct to antibiotics. Okay. So coming to the direct effect of hyperbaric oxygen therapy, it is usually as an antimicrobial. It induces the oxidative stress, whereby it disrupts the nucleic acids, which in turn leads to protein breakdown. So that leads to its antimicrobial property. I'm repeating it again. It induces oxidative stress, that is usually by the production of reactive oxygen species or reactive nitrogen species, wherein it breaks the nucleic acid, which acts to act forward to help in building of proteins. So that is disrupted. So there's no protein, or there will be protein breakdown, which leads to antimicrobial property. So the effect of hyperbaric oxygen therapy as an anti-infective is either as a direct bactericidal or a bacteriostatic effect. It usually acts as an additive or a synergic tool, especially with the use of certain antimicrobial drugs like aminoglycosides, trimethoprim, sulfamethoxazole, and vancomycin. Always remember, hyperbaric oxygen therapy per se is not found to be superior for sepsis. It has to be used as an adjunct. Okay, so first, whenever you have sepsis, you can't start the patient on hyperbaric oxygen therapy. Start these patients on the routine way of treatment. Probably it can be used as adjunctive therapy, especially in resistant organisms. So you can write hyperbaric oxygen therapy as known modalities of treatment for sepsis with resistant strains. Okay, so there are a lot of treatments which are coming forward, like phage therapy, monoclonal antibodies. Okay, probably extracorporeal therapies. In one of those, we can also add a hyperbaric oxygen therapy. Okay. So hyperbaric oxygen therapy's influence on host immune system is basically it causes overexpression of growth factors and downregulation of chemokines, especially the pro-inflammatory markers like interleukin 1, interleukin 6, and tumor necrosis factor alpha. HBOT, I told you, it is adjunct to an antibiotic. Okay, it can never act alone. Most of the times, it is usually causes anaerobic conditions, which causes the lysis of the bacteria or fungus, which is there. Okay. What are the contraindications of hyperbaric oxygen therapy? The absolute contraindications are untreated pneumothorax, because it can risk, I'm sorry for the error there, risk of worsening due to pressure changes. Concurrent use of certain medications like doxorubicin, cisplatin, and bleomycin. Okay, usually it causes potentiation of toxicity exacerbation with doxorubicin. Cisplatin, it causes reduced efficacy. Bleomycin, it can increase the risk of pulmonary toxicity. Bleomycin as it is can cause pulmonary fibrosis, but by the use of bleomycin with hyperbaric oxygen therapy, probably will be fastening the process of pulmonary fibrosis. So that is why whenever the patient is on bleomycin, there is no hyperbaric oxygen therapy is absolutely contraindicated. If the patient has any middle ear or a sinus surgery, it is contraindicated. Relative contraindications are patients with severe COPD, probably because they might have bullous lesions and that can cause, a barotrauma or a pneumothorax. History of seizures. If the patient is already having seizures and is on anti-epileptic therapy, as we all know, Paul-Bert effect is one thing which happens. There will be increased production of reactive oxygen species in the brain, and that can reduce the seizure threshold, and that is going to trigger a seizure in that patient. Okay, so that is one thing I need you to remember. Also, you remember we saw that there's a huge chamber in which the patient has to be placed. So if at all monitoring of the patient becomes problem, one is that is the relative contraindication. The other thing is patient would not be comfortable in that because of claustrophobia. So that is a relative contraindication. Pregnancy, optic neuritis, recent thoracic surgery. These are all things that they have still to be studied. So larger trials are not there. Pregnancy, especially, the effects of hyperbaric oxygen therapy in fetus is something that is still being studied. So these are all relative contraindications for hyperbaric oxygen therapy. So remember, hyperbaric oxygen therapy is one of the newer modality to treat resistant strains. It is mostly as an adjunct. In sepsis, it can be both, antibacterial or antimicrobial, both antifungal as well. Along with this, you need to remember that it causes oxidative stress, disrupts the nucleic acids, and breaks down the proteins, so that thereby enhancing the killing of the bacteria. So downregulation of pro-inflammatory markers is also something that we need to remember, that cytokine storm part of any sepsis can be mitigated by the use of hyperbaric oxygen therapy. Okay, so these are the slides. Thank you. Any questions? You guys are free to ask. Recently, in the session we had, you guys had spoken about how to approach or answer drugs, and I've seen the chat box that few of you have asked for, how to answer drugs. I recently had presented in one of the classes, and then I have few slides. I just like to show you those slides. Okay, what book Srihari has already shared. I think so. It's a very nice book, and that was one of the books that even I studied for my exam long ago. So this is one thing I wanted to share with you guys. Just give me some time. Yeah. Okay. So whenever they ask you, right, so they answer them under these headings, that is, antibiotic class, dose, mechanism of action, and adverse effects. And this is something that I just wanted to add because I have some time that I can spend to you. There are a few drugs which have already been uploaded by Dr. Bhuwana in the recorded sessions. You can go listen to them. There are a few antibiotics, especially the newer ones, which she has already mentioned there. Okay, but in case they ask you drugs, usually it will not be for more than 3 marks or 4 marks. It will be as a subheading. So whenever they ask you as a sub question, better answer them under these headings. So if you answer them under these headings, you would usually get most of the marks that is necessary. That is antibiotic class, the dose, mechanism of action, and adverse effects. So here I'm just taking an example of ceftazidime. It is a third generation cephalosporin. What you need to remember is it is active against gram-negative bacteria, that we all know. But adding the point that it is active against even Pseudomonas is something that it is necessary. That is, it's an anti-Pseudomonal antibiotic. So you need to know the dose. It is 1 to 2 grams every 8 hours. Okay, 8 to 12 hours it's usually administered. You should also know the route of administration. We all know cephalosporins acts by inhibition of bacterial cell wall synthesis. That is, it binds to the penicillin binding proteins and disrupts the peptidoglycan cross-linking. So always remember adverse effects. Please mention your regular, nausea, vomiting, etc. But more than that, what you need to understand is there are a few things that has to be addressed in a particular antibiotic. So you need to mention specific things, like if it's imipenem or any other carbapenems, mostly imipenem, you need to mention about seizure. When you're talking about fluconazole, you need to mention about, immunosuppression. You have to talk, bone marrow suppression. You need to talk about all those things as well. Okay. So I'm talking about the next drug, linezolid, if you're taking, right? So in this as well, you need to know what it acts on, whether it is a static drug, whether it is a cidal drug. These are things that you need to talk about. Okay. As we all know, linezolid causes myelosuppression, thrombocytopenia, something that we see, right? So this is something that you guys need to mention about. So each drug has its specific thing. Make sure that you guys write a few things about this and keep aside, so that when it's exams, you don't have to run around. If you have answered in such headings, probably you will be able to remember it in the long run. If you go read textbooks again during your exams, it will look Herculean and you might feel scared also. So instead of that, gather 2 or 3 points and then mention it. So that will be helpful for you. Okay. We will be sharing a few slides like this once in a while, so that it will help reduce your burden of preparing it. I know it's really difficult at this point in time where you have to read a lot of things. We will try and provide such summaries as and when possible. Okay. We'll put up a few slides like this each day so that it will help you guys. So this is what we thought we can do best. So another thing is, you guys are asking about transplant. We are going to start talking about brain death, end of life care, etc., and management of a potential organ donor in the next session, that is next Sunday. But organ transplant per se, we will be trying to cover at least 1 or 2 transplants. Probably liver transplant is what we are thinking of covering in the miscellaneous section. So I think so that should help you understand a basic outline to how to answer a transplant related question in your theory paper. I think so that should help. Any question?